Hey everybody, it's Ashley, physical therapist with TravelTrim Corporate Wellbeing, and I'm here with Dr. John Burleson. He is an orthopedic spine surgeon, presently with Houston Clinic in the Middle Tennessee area. Why don't you tell us a little bit about yourself, your training, and why we should be listening to
Excellent.
you?
Thank you. So, like Ashley said, I'm Dr. John Burleson. I did orthopedic surgery residency up in Massachusetts, which I enjoyed, but I'm thankful to be where it's a little warmer here in Middle Tennessee. I did a spine fellowship for a year, which is just a dedicated year focused on spine care and spine surgical care as well. And I did that at Texas Back Institute in Dallas, which is one of the bigger spine fellowships in the United States.
And very renowned.
Yes, it's a great place. I don't want to sell the place short, but it was a great year. Then I came up here with the goal of really taking care of a lot of the people in Middle Tennessee in general in terms of things that we could maybe do operatively, but as what we hoped, and it's proven to be the case, about 80 to 85% of the people in the clinic end up not needing surgery. So we're helping to kind of quarterback their spine care and their overall well-being in that way. So Houston Clinic, which is where I'm working, it's just been a great group in facilitating my ability to see those patients and really care for the area.
Wonderful. And I will also say he's my spine doctor, so I trust him implicitly.
I'm glad you did, because HIPAA keeps me from saying that, but I appreciate you saying.
I don't mind saying it at all. I brag that he's my doctor. Okay, so Dr. Burleson, I have a couple questions for you. One of those is, how common is back pain in terms of just the general population?
So this is one of the questions that we get all the time in terms of numbers, and I can tell you that every time I see a talk on back pain, the number's different, and it's 200 million people will experience it in their year in the U.S. or in their lifetime, or 150, and I'm not sure what the exact number is, but almost everyone at some point in their life will get some kind of back pain. Now, there's really varying types of that. There's the back pain because you decided that all of a sudden you were gonna, shovel and rake a bunch of snow for 3 hours or something, or rake a bunch of leaves, and you don't normally do that. You're sore for a day and it gets better. And then there's the more every day I have chronic back pain type problems. So there's a wide spectrum of that, but I would say anyone who's made it to adulthood has probably experienced at least some stint of some discomfort with their back.
So incredibly common.
Very common. Probably, I'm biased as a spine surgeon,
right,
but probably one of the most common health issues in the country.
And one of the largest forms of disability in the United States of America.
Well, the biggest problem with your back is that, as I tell people all the time, if you sprain a muscle in your arm, not to get into the minutia, but we could always just put you in a sling for a couple days. I'm not recommending that, but you could do that. You can't put your back in a sling. You can't not use your back muscles. And as we figured out over the last 50, 60 years of medical education, is that resting your back too much is normally counterproductive. So just going to lay in the bed for 5 days because your back hurts normally doesn't make you feel better.
Right.
So it is a bit of a conundrum because there's lost hours at work, there's lack of productivity with your family and your friends, and then just the mental stress and duress that it can cause from having a chronic issue if it becomes a long-term problem.
Which I do want to touch base on with you a little bit later about the thought processes and belief systems behind back pain.
Absolutely.
And how that plays into disability. We'll get to that. I wanted to go more down the road of the most common low back diagnoses that you see.
Yeah, so I think when someone comes in and sees me and they have low back pain that is, let's say it's been going on for 2 months, but it's a new thing for them in general. They normally function without back pain. In my head, I'm already thinking about what things these could be. And I'm thinking about what tests can we order that might help us figure that out? What treatments can we order that are not going to cause us harm if it's for the wrong thing, for instance? And in that regard, most people that come in with a back problem that are able to walk, so they weren't in a car accident basically. Those people, I'm sending them to physical therapy because the most common problem is a lumbar strain, is a tear of a muscle in your back that's not a complete tear. It didn't completely come off, but it's torn enough that it irritates them every time they stand up straight, sit up straight, use their back. The other, probably the second most common, or at least the second most common diagnosis that I see, is that some type of disc herniation in their back. And so those patients also tend to get better with therapy. So for the same reason, I would send them to therapy to start, but that would be something that down the road an MRI might help us see a little bit more of. So in my mind, I have the muscular problems or musculoskeletal problems, and that includes everything from arthritis to the muscle strains, and then we have the neurologic problems, and that's a bulging disc pressing on a nerve root, things like that. And a good physical exam can help narrow that down. But fortunately, we get to cheat a little bit, and by utilizing time and therapists, we're typically able to get them active and mobile and feeling better without having to intervene, and then we look really smart without taking on any risk. So.
Right. And just because, for whatever reason, our human condition goes to worst case scenario,
right?
How frequently do you see tumors and cancer, and how frequent is that?
So great question. I get asked that all the time when I pull up an MRI and I'm telling them how they have this disc herniation, and I can see them kind of looking through me sometimes, and then I'll say, do you have a question? They're like, but you don't see cancer.
Right.
Everyone's always worried about that,
right.
And which is fine because we all know someone. It's exceedingly rare. I can tell you I've had one patient that came to see me from a cancer hospital. They knew they had cancer and it was causing some issues with their back. And we had one patient, I've had one, that I got an MRI on that we were not expecting to see masses, and we saw some masses. And that was, obviously, it's an unfortunate conversation, but we're able to immediately get them to where they need to go to get some care and figure out what's going on. And that's no more fun for me than for the patient. Obviously, we're wanting to get people back to life, and you see that, and it's not fun. But the vast majority of the time, we're getting an MRI that looks what I would call normal or age appropriate, and nothing that accounts for their pain, which typically means it's the musculoskeletal stuff. It's an alignment issue. It's an activity issue. And then occasionally we're seeing a small disc herniation or arthritis, and we obviously tailor the conversation for that.
And back to the fear of pain, even with a disc herniation, that doesn't mean that they're going to be disabled or have pain for the rest of their life.
Absolutely not. I mean, I've had, single-digit patients that come in where I'm even thinking in my own head, oh man, this is not really a fixable problem. These are people that are admittedly in their 90s and have had 8 surgeries, and that's a tough problem. They know they have a tough problem. People that come in, they frequently don't see the light at the end of the tunnel, and they get into this circle of negative thoughts and almost kind of depression about pain or disability. Almost all of them, probably 15 and 20% here need spine surgery. Almost all of them are able to get better without surgery, and that's what we're going for.
Right.
But as I remind them, and of course I'm biased because I'm a surgeon, if we have to operate, it's not like we're operating and now you're going to be in a wheelchair the rest of your life. I mean, when we do procedures here, when I do disc replacements where I'm trying to keep motion moving and get pressure off the nerves, or even a decompression where I take out that disc herniation, those are things I'm doing to get people back to life. And the most common question when I indicate someone for surgery is, well, what am I going to be able to do and not be able to do? And I tell them that your mind frame is off. It's not about limitations, it's about time. There's a time where I'm going to hold you back. But at 3 months, if you want to jump out of a perfectly good airplane, that's on you. But I'm going to let you do it, right? And that's whether they have a big fusion or a disc replacement or a discectomy. Is that the goal of any modern spine treatment, whether it's physical therapy or a 3-level fusion, is to get them back to life, not to take them out of it. If they want to be disabled, don't go seek care anywhere. Just hide in a corner, right? That's why we try and get people to come in when I tell them what therapy can do for you, just being active and learning the right exercises, what some anti-inflammatories can do sometimes, what a steroid pack can do. I mean, that stuff can really be surprising sometimes, where I see people hobble in and on their next visit, they're skipping in and they're like, do I need to come back? It's like, this is great, know? So there's a lot of options. The important thing to remember is there's a light at the end of the tunnel. It's not a train. There are good
I like
things.
that.
Yeah.
I'm going to use that. I'm going to steal that. So, continuing on the low back pain and being very common, do you see a thread of commonality in people that come in with low back pain? Is there an age commonality? Is there a body composition commonality? Is there a mechanism of injury commonality, or is it sporadic?
So there are certainly some trends that I'll get into. I think we do see it everywhere. So it's represented in every group, not equally, but every group. Now, you don't see a ton of teenagers with lumbar strains. It can happen, but it's just not very common. I would say probably the most common age group that is represented in terms of new or acute low back pain, 30 to 50. And I think, and this is my own bias, is that as someone who's in his 30s, that in your 30s and 40s, we really struggle with being in our 30s and our 40s and not being in our 20s anymore. And so we think we can do some of the things that we used to be able to do. When you're 20, you cannot play whatever sport it is you play for a month, and you just go pick it up, and that's fine. That is not how the world works when you're getting a little older. And so that's kind of, I see a lot of lumbar issues that are for that. And almost all of those are better within a month or two. But that makes up probably the biggest segment, is that age group. And that can be from I was trying to be athletic to like I was cleaning out the garage and I was just doing more things than I would normally do. The myth I want to dispel is that most back pain comes from sliding into second base or picking up a car. Like, most of them are not from that.
Right.
And a lot of people will tell me, with neck and back pain, they'll say, I woke up like this. Like, I must have slept wrong, and it just lasted a couple days, and then they came to see me when it was still hanging around.
Right.
Most of the time, we don't have a big, aggressive mechanism. We have some people that get hurt at work, lifting up something heavy. Sure, that happens, but that doesn't make up as big a percentage as you would think. Most of them are what I would call like normal people doing normal things, and their backs hurt.
Totally makes sense. Let's shift a little bit to neck pain. So I'm going to differentiate neck and back.
Okay.
Is neck pain something that you see a lot?
Yeah, I do see a lot of neck pain, and I think there's a lot of talk recently about things like text neck and all this stuff with your phones where you lean over. I will say, in the opposite of a self-deprecating way, I haven't practiced before cell phones. So I've always, in residency training and fellowship and being out now, I've always existed in that world, and
you've always had a device.
I've always had a device, and since I've been someone taking care of people, devices have been around. So it's not like I could appreciate a new wave, but I'm telling you, it's really common, and it's probably less common than back pain, but we see a lot of neck pain, especially with people that sit at a desk all day, or people that are on their phone a lot. And I think, we talk about ways to alleviate that, and posture and ergonomics and all these things that are incredibly helpful. And that's really the majority of the causes for that. We do have a small percentage, just like back pain, that have these issues because they have a spine deformity. Their spine's not shaped in the right way, so their muscles are struggling to hold them upright. That is in the minority of patients, and we figure that out early on, and we go through what we have to go through. Most people have it because of their posture, and they have their monitor down really low. It's always surprising to me when you go into someone's office and sit at their desk, and the middle of their monitor is not at their eye line, it's down here, and you're like, this is what you're doing all day, every day. Little changes like that I think can help people in the long run, and that's normally just a conversation and a few PT visits, and then they're back to where they want to be. But I'd say that's probably the majority of the neck pain that I see, and that even that my partners see that don't make it to me because they've learned that spiel that they give to the patients, and then they don't end up seeing the surgeon.
Got it. How frequent are traumatic neck injuries that you see?
Yeah.
I mean, obviously you see them.
Yeah. So fortunately, not extremely common. They are a tough problem to deal with. So I work mainly at like a level 2, level 3 hospital, which means that we get stuff that comes in, that people come in, or if the ambulance brings them and they didn't know they had an injury. If someone dives into a shallow pool and can't move their arms and legs, they take them to a trauma center. So I did my training at places like that. And even there, they're very rare, which is excellent. The most common traumatic injury I get is someone that was in a 30-mile-an-hour car accident. Car was damaged, they felt okay, and then the next day everything feels really stiff and sore, and they want to know, do I just have whiplash, which is a strain of the muscle, right? Or did I maybe hurt my neck a little more, and I don't want to do something that's going to make it worse?
Right.
Most active people realize with whiplash, okay, it's going to hurt, I'll take some anti-inflammatories, I want to push through it. But like any athlete, you learn like there's injuries you can push through and there's things that you should not push through. And obviously if you have a broken neck, you don't want to push through that.
Right.
So I get a lot of x-rays for that. We probably get a couple a month where people come in with that concern. I've had very, very few, and they're all picked up in the hospital. Here we get x-rays to make people feel better with that story.
Right.
But fortunately, it's pretty uncommon. The human body is insanely able to deal with a high amount of stress, and car accidents included. I mean, when you get whiplash, for instance, it's literally your muscles trying to keep your head from flying off your body, basically.
Right.
And the reason they hurt is because they work, because they do it. They keep your head on your
right.
body, So fortunately, it's not a big part of my practice, and it's not a big part of most spine surgeons' practices, but it does happen occasionally, normally at major centers.
So with the company that I'm with presently, it's a lot of manufacturing plants and factories.
Yep.
So the trauma is generally either a car accident or a fall from a ladder or a slip onto a concrete floor.
Right.
What are the red flags that should tell someone I need to seek medical care versus let me just see how I feel in a day?
So that's a great question. So The biggest things that I think about, and you would know this if you come in and you're one of those patients, because it's going to be the first questions I ask is, do you have any arm pain? Like if you hurt your neck, I'm going to ask, do you have any arm pain? Do you have any leg pain? Because if you damage your spinal cord, if something is broken and things are moved, the scary stuff, you're going to have nerve problems. If your neck hurts and your neck is sore, and especially if it's worse when you touch the muscles, then we put it in that musculoskeletal category. Now in the clinic, if you're here, I'm going to take an x-ray of you. But if I was in the hospital and someone slipped and they hit their head and they said my neck is sore, but they can move it around okay, their arms are fine, their legs are fine, most of the time we would say that we're thinking this is just musculoskeletal. It's not medical advice, don't hold me to that. But that's kind of the way we think
Right.
about that. And if that happened to my friend, that's what I would tell him. Give it a couple days.
Right.
Anytime you have weird electrical feelings, neurologic sensation, my arm is weak, pain shooting down your arms, things like that, then we'd say, stop what you're doing, go to the surgeon or go to the hospital, get x-rays and make sure. And what's worth noting is even most of those people are fine.
Right.
But that's our, when you talk about red flags, if we sent all those people in, we're going to catch pretty much everyone that has a real problem. We're also going to catch a lot of people that don't.
Right.
But the way I view what I do is I need to have what we call high sensitivity. So I need to be very sensitive to capture things, and I'm very risk averse. So that way I don't make a mistake and miss something. But we shoot a bunch of x-rays here on people that are normal for that reason.
Mm-hmm.
But that's what I tell people. It's reasonable to tough it out if you're sore. You have weird symptoms you haven't had before. Don't be a hero. Go see someone.
And as a PT, I'm going to go ahead and say some of the things that people don't often equate to potential spine injuries are bladder and bowel and
Yep.
paresthesias in the area that if you sit down on a bike or on a saddle, the saddle paresthesias,
Yep.
people often don't associate that.
Right.
But if you fall, hit your head, or slip and have those symptoms, they need to
Yes.
come see you.
Absolutely. And I would say, yeah, if you're outside the building, I'd bring you into the office. Otherwise, I'm going to tell you to go to the hospital. And it's because in the ER, we can get the CT scan quickly and look. We don't frequently think of things like in the genital region as being nerve related, but they're all driven by nerves.
Right.
So, I've probably treated somewhere between 10 and 15 people that have had an emergent issue with that in training at major trauma centers, so high volume areas. And when you look at the symptoms they come in with, that saddle anesthesia or saddle numbness is very common. Bowel and bladder incontinence, where someone will say, I pooped or peed and I didn't mean to. And we distinguish that. That's not, I couldn't make it to the bathroom because my back hurt. That is, I looked down and I was just peeing the bed, And then the other thing that's common and is embarrassing, so it doesn't get brought up, is male sexual dysfunction. So they'll say, I had an erection that didn't go away and I don't take any medication for that. Those types of things can be related to the spine injury. So, it's because the nerves that go to that whole area are the last nerves on the spinal cord. Anything that is abnormal, you want to say it's better to rule that out and make sure everything's okay. And the main reason behind that is those symptoms, the ones you discussed, are the ones that are potentially irreversible. Things like pain and numbness, even when we find disc herniations, we can sit on that sometimes because if it gets better with therapy or better with anti-inflammatories, the symptoms go away. When you start having muscles that are weak or sexual dysfunction or numbness around the genital region or bladder control that you lose, that might be gone forever if we don't address it.
Do something quickly.
Right. Now, again, this is extreme minority percentage of the population, but
Just
if
the red flags.
the friend tells you they can't pee all of a sudden, don't let them, tough it out.
Got it.
Drive them to the hospital.
Got
Don't
it.
let them drive either.
So rare, but
Rare, but you should know that.
dangerous.
Correct.
Okay. Now let's go back to some common beliefs around back pain. Something that I hear a lot in a clinic is, oh, my mom had a bad back, so I'm going to have a bad back. Is that true?
There's some level of truth to it. The joke we always tell when they say is, what can I do to make this back pain not happen, or what can my kids do, is we say, well, be more careful when you're picking your parents. Because, there is some level to truth about the genetics of it. We think that that's more related to the alignment of the facet joints, which are the joints in the back. Maybe they're tilted a little one way or more in your family line. Same thing with like knee arthritis, that maybe the joints just shaped a little bit different. And we know that different groups of people from different parts of the world have different anatomy that might predispose them to some of those problems. So this is the nature versus nurture argument, is that there's the people that will say, well, to give the knee as an example, because everyone can relate to that, someone will say, well, I played running back in high school and so I have bad knees. Well, maybe, but maybe you just have bad knees because you have bad knees. And There are obviously examples if they say, yeah, well, I dislocated my knee 3 times. Okay, well then that's probably true. But most of the time, people that have bad knees, they just also happen to have played football, and it's unrelated. With the back pain and back problems are so common that it's also likely that you just happen to have back pain like your mom did. The problem that we run into is something that I end up having to unwind a lot is back pain, symptoms from back pain, back surgeries are all so different. It's not like saying my uncle got a knee replacement and then he's getting a knee replacement. Those might be very, very similar. But when someone says, oh, I'm not having back surgery because my mom had that and now she's in a wheelchair, well, she had it 40 years ago and she had a 10-level fusion, and I'm telling you that you need a discectomy, those are very different things.
Right.
And so they might say, yes, she had a back problem and I have a back problem. The back is, think of the back as 26 knee joints, right? Like it's just a bunch of different things going on. So where you have a problem, to what degree that is, there's probably some genetic component, but I certainly wouldn't, if you're in your 20s and you see that your dad's getting back surgery, I wouldn't think, well, great, I'm going to get back surgery. Like it's probably not a lot more likely than the general population.
Got it. Okay. Because I know that's fearful for a lot of people.
Absolutely.
And then let's talk a little bit about prevention.
Okay.
We want to take best care of our spine. What are some things that people can do on a daily basis that could be preventative and helpful?
I think the single best philosophy in general is that motion is lotion. So if you're able to stay moving and stay active, that helps you in several different ways. It helps you because from a musculoskeletal perspective, you're ranging your joints, you're maintaining pliability, your muscle mass is higher. You're able to hold yourself with correct posture because your core strength is good. You know, if you're a guy, guys tend to be, especially guys that work out a lot, we tend to be really chest dominant, and then you're just bringing your shoulders in. So working out your whole body in a way that you're active is great. And that doesn't mean you got to go to the gym 5 times, but it just means staying active. The other thing that helps with is weight. So one of the worst things you can do for your back is to weigh 400 pounds, right? Because every pound that you put on your body, you're putting multiple pounds through your lumbar spine, and the lower down the spine you go, the more weight it's got to hold. So as
400 pounds is pretty extreme.
It's extreme.
So let's get real.
Yeah.
Like, what's, in your opinion,
yeah,
how much should people care about what they weigh, and what would be considered obese
sure
versus healthy?
Yeah, so this comes up a lot because, you know, so we use BMI in our computer just like everybody else does. So the BMI comes up and they have their own readings for what that means. So I'll tell you, I'm 6 foot tall. I weigh like 192 pounds. I should weigh like 182, but you know, whatever. I have little kids and chasing after. But if you look at the thing, I'm either overweight or really close to overweight, and maybe I'm biased, but like I don't really feel like I'm super unhealthy.
Right.
So I don't know that those numbers are really the cutoffs that we need. I think, assuming that you're not someone who's a professional athlete, because like a left tackle on a football team is morbidly obese, but is very healthy for the most part. I think what I would say is, you know, if you take your ideal body weight, which is, you know, for a guy that's 6 foot tall, you know, my ideal body weight's probably 175 or so. If you take that and you add 50 pounds to it, it's probably a little much, you know, and at that rate, you're normally not in the overweight, but you're in the obese category. If you find that your weight is in the obese category, which is a BMI of over 30, it's probably worth considering whether or not you need to lose some weight, or if you're there for good reasons. You know, if I, you know, went back to when I was in college and I was weightlifting and stuff, then my BMI was close to that, but I was not unhealthy, you know, and I was doing the right things. And so there are exceptions to the rule. And I have a patient who is a bodybuilder here his BMI is 32, and he shouldn't change anything. I mean, so there are situations that are exceptions.
Right.
The problem is, outside of those glaring exceptions, we don't want, like, almost everyone comes up with a reason why they're there, and then that might be the reason why they're overweight, but that is not necessarily the reason why it's acceptable to be overweight. And so as I talk to a lot of people about weight loss. It's a very common topic I get into. I'm very careful to hit on a few points. It's not personal. It's not a judgmental problem. It is factual. The number's real, and there is absolutely a path to fix that problem. And then I always end with the same thing. I'm not saying it's going to be easy. I'm saying it's worth it. And that it's worth it to, not only in some of these patients, they can't have surgery because their BMI is too high. BMI over 40 in most situations precludes you from surgery. So patients,
especially spine surgery.
Absolutely. Our infection rate goes up, complication rate goes up. patients are always shocked to hear that the insurance company has been cashing their check but will deny their surgery based on their weight. I tell them that it will fix other things. Sometimes they don't even need me after they lose weight, which is great. But then if they do, we can mitigate those risks. So outside of the surgical population, to get back to what you were talking to, if you're 50 or 60 pounds over what your ideal weight is, and that's, you can see that online for whatever your height and body composition is, then I would seriously think about not a diet, but a lifestyle modification. What's one thing I can change every week? What's a way I can cut out 100 calories a day that's sustainable? What's a way that I can walk for 30 minutes more a week than I'm not now? Or some activity I can get involved in exchange for another one that's more active than the one I'm involved in. Little things, but they have to be sustainable, because the diet just ultimately ends up in more weight gain.
So would you say that 50 or 60 pounds, is that for a male frame and a female frame?
That's tough. How tall are you?
5'2".
Okay, I was gonna say, so shorter women complain about this all the time, because if you're 5 foot tall, for instance, if you gain 10 pounds and I gain 10 pounds,
it's very different.
It's different, right? Like I can hide, I got more places to hide that. So it's tough, because for women that are 200 pounds, if you're 200 pounds and 5'11", it's not a big deal.
Right.
And the only reason I'd say it's different is not so much because of the gender differences, but because there's just not as many guys that are 5 foot tall.
Height difference.
So it's a height difference where it really matters. And that's why the BMI does take that into account a little bit. And some of this is not an exact science, but it's, with people outside of medicine, it's I had a look in the mirror moment where I was like, oh man, we got to change this, But from a health perspective, I'd say I don't want people to, there's probably a more PC way to say this, but like body positivity is great, because we should all be comfortable in who we are and what we do every day, and our interactions with people, and what we're going to do, and the impact we're going to have. But in the same regard, it's how I look at how I deal with the country. If you don't like something about the country, it's okay to say that, because you care about it. You want them to change something, make something better. It's the same thing with your body. You should be able to be confident in who you are and what you are up here, and still be able to say, but I want to change this about me to get the best me out of it. And I don't think those are mutually exclusive thoughts.
Correct.
And I bring that up just because some of the body positivity movement has resulted in people saying, accept me for who I am, at what, as a physician, I would say is potentially unhealthy, and that worries me, because I want people to be as healthy as they can be.
But we know there's a relationship between being overweight and back pain.
Yes.
Okay.
Correct.
All right. Anything else? What about hydration, water intake? Is that important for spine health?
I think indirectly. The discs have water in them and all that help them be shock absorbers, but that's not probably related directly to the day-to-day intake. It's very related to the rest of your organs and to your functionality and your energy level, and replacing, sugary drinks with things like water should be mandatory. And this comes from someone who unfortunately drinks too many energy drinks, sugar-free, but I drink them. But the water intake for a lot of people is lower than it should be. And we see that when we bring people into the hospital for surgery for whatever reason, and we get their labs and you see, oh, you're really dehydrated and you haven't even done anything. So I think that's, not a lot of people out there are drinking too much water. So
now, obviously, osteoporosis isn't a work-related injury.
Correct.
But it's a big issue in the spine.
Right.
And all of those things help osteoporotic changes as well, which does lead to pain and dysfunction.
Absolutely. Osteoporosis for the older population, especially, I call it the curse of older white women, because it's the white population the most, but it can affect men and darker skinned individuals. And it's a problem that we care a lot about, because it's harder to fix. If you break your wrist, we can fix it with metal if we have to, and that sucks, but then you're done with it and you're back to being you. Osteoporosis is like an enemy that's there that we're constantly trying to fight against. The best way to fight it is to prevent it. And so prevention of osteoporosis, vitamin D, calcium, occasionally medications if your doctor thinks that's right for you. But for most people, to what you were alluding to, it's loading your bones. Not with your body weight, but with your exercise. Right. And that can be with everything from light weight resistance training to even things like running and walking really do load your bones and help slow down your bones kind of going away over time. So, and you kind of alluded to this with the work injuries, is that there are work injuries because a box fell and hit you on the head. And then there are work injuries where something happens at work, but you had some predisposing thing in the background. Now that's still a work injury, because had you not been there, that would not have happened. But there are things that you can do that will make you less susceptible, or make it where when something happens, it's less severe than if you hadn't done those preventative things. And that's where being in good shape, having good bone health, all those things will make you more resilient in the face of some issue.
And you mentioned core, having a strong core.
Absolutely.
It's important. But I love what Dr. Burleson said. It's not just about the abs.
Right.
It's about balancing the muscles out.
That's right.
Lumbar spine, hip, as well as abs.
Yeah, and it's, because we extrapolate from the chest too, that's the problem, is that if it's almost worse if you're someone that goes to the gym once a week and you just do, like as a guy, you do the show muscles, right? So you do your biceps and your pecs. Great, but you eventually, you do the crunches and you do this and you walk around like this. And if you ask people for every time that you've done a set on the pec deck, how many times did you do back extensions? It's not a good ratio, right? So you're right. It's more about balance with the chest. I'll tell people every time you go and do bench press, you need to do the fly machine or something to help your back and the muscles between your scapulae strengthen themselves, so you don't just become someone who's pulling your shoulder blades around the front of your body. And with your core, people are always interested to learn when I say, I'm going to send you to therapy because you have a lumbar strain and you're going to work on your core. So it's going to be your abs and your back muscles. And they'll say, well, I'm going to work on the back muscles when the back muscles hurt. And I'll say, yeah, because there's a bunch of them back there. Right. And if you strengthen the other ones, they will offload the injured one and they will stretch out your core anteriorly. And then when you do your abs, you'll do some stretching of the back, but we're not going to go crazy with the crunches, and then they find themselves that slowly over a few sessions and at home doing their own exercises, that they walk straighter, the pain bothers them less, and they all say the same thing, especially those that were less active. I feel like I have more energy now. The pain is gone, but I feel more energetic. And then I realize that they're getting the dopamine hit from working out. They're doing the workout, which makes you feel better, which makes you see more light at the end of the tunnel, and it makes this positive feedback loop.
Light that's not a train.
That's not a train, that's right.
Okay, so let's go back really quickly to, we talked about device and technique and posture.
Yep.
Obviously, strengthening will help posture. What are some other tips that you give people to improve posture-related pain?
The biggest thing is, if you find yourself at work or at home sitting in the same chair or working in the same environment, it's worth the time investment to make sure that environment that you spend a lot of your time on is the best for you. So we've been hearing it now for a couple decades, but that's what the mattress companies would say, right? You spend a third of your life on the mattress. Hopefully it seems like a fifth of my life now, but I'd love for it to be a third. But no one would say that it's a good idea if you're making a living to go out and buy a $200 mattress. Like, no one would do that because you spend a lot of time on it. It's probably worth the investment. But at the same time, they'll go spend $50 on an office chair, and a $150 office chair seems ridiculous. And I would argue that your employer should certainly have an interest in that. But even if they don't, it's your back.
Right.
You should do something about it. And so the things that I think about are lumbar support. If your car offers lumbar support, then I would turn that on. You want it really as high as it can be. And the key is the lumbar support's there to curve in the middle of your lower back. So if you turn that on and then you slide your butt in front of you, that doesn't do anything, right?
No good whatsoever.
So what you do is you put your butt all the way back and then you lean over that arch, and it gives you that lumbar support, which allows the discs to be loaded in the direction they're supposed to be loaded. We want to always avoid using our back like a crane where we lean forward. And the problem is we're either doing this or we're slouching, and slouching is absolutely terrible for your back. So the other thing I would say outside of the workspace is the lounge space. It's okay to have a soft couch. If you're someone who has back pain all the time, you don't want the softest couch. It's just going to make you worse. And I mean, anyone's listening to this that's gone through this will know what I'm talking about. You sit down, you feel great for 10 to 15 minutes, and then it starts to ache, then it aches more, and then you spend hours trying to fix it, and then you go to bed because you can't, and even in bed it doesn't get better until the morning, if then. And it's all because in the beginning there's always a positive feedback. It's like food. You're like, oh, this is great. And then you look in the mirror and you're like, oh man, why did I do that? And the next morning you haven't lost any of the weight you wanted to, right? And that's what it is. But you set yourself up for success. So with the food, you meal prep, or you don't buy, I don't buy certain things in my house because I will eat them, right?
If it's there, I'll eat it.
You'll eat it. And the same thing with the couch is that if I'm having back pain all the time and I have really soft furniture and I have no lumbar support in my office chair, change those things. And those types of things where you spend the most time, if you fix those, then yeah, if you're sitting in a waiting room that has whatever chair or you're awkwardly standing somewhere else, it's not going to be a big deal. But where you invest the most time should be ideal and are worth whatever financial investment makes sense to you because it's your back.
Right.
So I think that makes a lot of sense for most people to at least evaluate those environments.
And if you're not sure what is most ideal for you, eliciting the help of someone who is an expert in that field
absolutely
will be totally worth it.
Absolutely.
One of the things that we tell patients that complain of neck pain that are on their devices a lot is even if you're standing at the grocery store, any time like this is going to feed into that poor posture.
Correct.
So just support your arm and look straight ahead versus down. Like small changes like that can add up.
And that's what's painful about the phone thing, is that with your computer, we finally figured that out, where most computer monitors can raise up and down, and you can put the keyboard in a reasonable spot. Well, there's no way to scroll through your phone down here and have the phone up here, right? So your arms get tired, and you know, this is like, I'd say probably against myself too, but the easiest thing to say is that if you're holding it up here and your arms are tired, you're probably done with your phone. You should probably put your phone away at that point, right? Like, and we could all look at the screen time and be embarrassed by how much time we spend on our phone. But I think all of those are definitely considerations. You're right. I mean, it's about the position of your neck. We want to minimize the time that we're just staring down like this. You're just stretching out the muscles in the back, and not in a good way. You're stretching out the facet joints. You're crunching down the discs. And, you know, the neck is meant to move, but it's meant to sit in this posture as it's standard, you know, not like this.
Got it. So let's summarize, see if I got everything.
Okay.
For back pain and neck pain, it's common.
Very.
But it can be preventable regarding outside of an injury. It can be prevented with some daily measures, movement, staying active, nutrition, which would help with the weight, so with the movement, and then working on posture, making sure you're balancing out your front muscles and your back muscles, and then making sure where you spend most of your time is ideal for you, for the alignment of your spine. And then let's talk a little bit about trauma and avoiding injuries. I know workplaces make sure they have OSHA, they make sure things are safe. But if you're working at home, from home, then you want to be aware of little kids' toys all over the floor. You don't want to fall and slip on those, especially if you have something like osteoporosis or degenerative condition. Arthritic changes.
Well, and the biggest thing that I run into is I still do a lot of orthopedic care outside of the spine. And sometimes when people fall, they hurt their back. Sometimes they break their hip, right? So we talk a lot about people that have osteoporosis. What can we do to prevent trips and falls? And it's actually really frustrating that so many older people that fall and hurt their hips do it the same way. And that's that there's almost always a rug involved, or a cord, or slip-on shoes. And you don't want shoes that slip on and off, because if you take the wrong step, it halfway goes off your foot and then you trip over it. Rugs are easy to trip over at night, and the same thing with the cord. So we have a whole lot of people out there that we fixed one hip and now their house is safe. But we'd like for people to do it ahead of time. So we'd say if you're at that age where you're getting up at night, having to use the restroom, or you have known osteoporosis, you can still have the shoes that don't need to be laced, but they should be almost like the boat shoe house shoes, that they cut something over your heel. There should no excuse for cords to run across the room. It's worth the $100 to have someone come out and put an outlet where you need it, or just have don't use a lamp, use overhead lights. And then for rugs, just don't do them. If you want carpet in the room, put carpet in the room, but don't do rugs, because rugs are so easy to trip over. And it's every time it happens, people come in, they feel really embarrassed and bad that happened, but it's not uncommon.
It's very common.
Very common. So the more time you spend at home, whether you're younger and working at home, or if you're older and have osteoporosis and just kind of living in your home, you want to think about those things, because it's not fun to wish later on you didn't do it.
And then to end this, I would like to talk a little bit about, in your experience, even if someone has back pain, even if they have experienced back pain for a long period of time, it doesn't mean that they're going to be disabled.
Correct.
It just means things need to change.
Yeah, and that's, the patient that comes in that's had back pain for a month is not necessarily different than the one that's had it for 2 years if the person that's had it for 2 years didn't do anything. Back pain is notorious, as we mentioned in the beginning, for not getting better with inaction. You normally need to work on it, because if you splint it by basically laying on the bed and not doing anything, then every time you get to some activity, it's going to hurt more and more. And that's how I see those people that have been dealing with it for a long time. They are coming in to see me with what I don't think they verbalize, but they're all thinking is this is forever. Right? This is a problem. He's going to say either I'm crazy, or there's no way to fix it, or I need some huge surgery. And it's not the case. I start with them like I was seeing them on the first month. I said, well, we're going to do physical therapy. Guess what? You're probably not going to get better after 2 sessions like the other person might, but we're going to start by loosening things up. We're going to get pliability back. We're going to have discussions about your daily activity. As they go to therapy and feel better about themselves, it's easier to then go on that walk later in the day, We put them on some anti-inflammatories so that therapy doesn't make them take a few steps backwards and they can just keep progressing forward.
It will make them sore.
It's normal. The problem is what's normal for therapy might not be normal for them. And
Right.
I take you back to the high school athlete situation. Like, yeah, if you go really hard in the gym and you're 19, you're going to be sore. Now, you might only be sore for 12 hours. I'd be sore for 5 days. But it's normal to
Right.
be sore. The reason why we do the anti-inflammatories sometimes is because I want you to have some recovery, but I don't want someone who hasn't worked out in 5 years to be so sore that they now can't perform at their next therapy visit. So we're just trying to speed up their recovery a little bit. But it's absolutely not the disability thing for back pain is much more of a fear than an actuality. There are people that have that, and I don't treat many of those, and some of them I kind of wonder how that came to be. But when we see people here, we make them better. It's just everyone's a little different in terms of how long, what specific treatment they need, whether it's going to be surgical or not, those types of things. But the idea that I don't want to see someone because I'm going to be disabled or whatever, that's, you're turning down a very large chance you're going to get better by getting some good care because you don't want to maybe think about the fact that this might be a long-term thing. So from my very selfish perspective, because I'm the doctor, you should see the doctor because there's a
Right.
really good chance they're going to give you some things to fix it. And it might not be the next day, but at least 3 or 4 months down the road, you're going to look back and be like, I wish I had done this a long time ago.
Got it. Well, thank you so much for your time.
Absolutely.
Guys, Dr. Burleson practices in Smyrna, in Nashville, and Lebanon.
That's right. Yep.
And I can personally highly recommend him. Thank you so much for your time. And yeah, we appreciate it.
Yeah, absolutely. Come and see me. Thanks. Awesome.
Thank you.